Some of the most valuable encounters that I have with patients are those young individuals who are not yet diagnosed with cancer themselves. What we can do as genetic counselors is provide some anticipatory guidance. We have these strategies that can help take people at heightened risk, promote earlier detection of cancer through certain tools like colonoscopy, for example, and ultimately lead to better outcomes. So often, what I tell my patients who have a known hereditary syndrome like Lynch syndrome is that we can see in subsequent generations, family members may do better than the individuals the generation above who didn't know they had this hereditary syndrome.
When I think of Lynch syndrome, I just think of this page in some medical textbook in medical school with just like polyps everywhere of the colon. I'm curious, how would you define Lynch syndrome?
Lynch syndrome is an inherited predisposition that increases risk for a variety of different kinds of cancer. The two most common are colorectal and endometrial cancer. Lynch syndrome is considered a non polyposis condition. So people with Lynch syndrome aren't going to develop, hundreds to thousands of polyps, but their risk of cancer is still significantly increased. To a lesser degree, Lynch syndrome can also increase risk for upper GI cancers, so gastric and small bowel, for pancreatic and biliary tract cancers, for urinary tract cancers, particularly their kidney and the ureter, the brain, the skin, and the prostate, and the ovaries.
Lynch syndrome, the polyps turn into cancer very quickly. So as you guys know, sporadic adenoma takes 15 or 20 years to turn into cancer. In Lynch syndrome, that's 3 years or less. And so that's why we recommend colonoscopy every 1 to 2 years, because can go from polyp to cancer very quickly, even with, between yearly scopes, we know cancers can develop. And that just doesn't happen in average risk people. So colonoscopy in Lynch syndrome has a huge survival advantage. So as a
Yeah.
GI doc, it's really rewarding for me.
Is there a good framework to think about who would be good people to refer to genetic counseling or to even broach that topic to?
Some easy ones are from a GI perspective. Any person with pancreatic adenocarcinoma should be offered genetic
Hmm.
testing. Any person with colon cancer should be offered genetic testing. Any person who has a mismatch repair deficient tumor of any kind should be offered genetic testing. And then, if there is a striking family history that you're picking up on in your questioning, then that would also be something to consider.
An abnormal mismatch repair immunohistochemistry or MMR IHC result, it's an indicator that Lynch syndrome may be more likely and further evaluations warranted, but it does not confirm a diagnosis since there are a percentage of tumors that will show mismatch repair deficiency, but it can be due to acquired reasons, somatic changes in that tumor, as opposed to something that was inherited. So I think that's also sometimes patients come in with a very high level of worry. Their doctor told them they have Lynch syndrome, when I need to slow things down at first and say, well, this warrants further evaluation, but it's not a diagnostic test until we get to that germline test often.
So germline testing is looking at like the inherited genes. And then the somatic testing is looking at the tumor cells and all the mutations that have developed as it goes from, a normal cell to a cancer cell. So all those acquired mutations in the cancer.
So nuanced. Interesting. I would just love to get some stories of why you feel passionate about the topic.
Since I've now been doing this for more than 10 years, I'm starting to now see the second generation come in the door from people that I originally diagnosed 10 years ago. And there was one woman whose sister had endometrial cancer in her 50s. And so that woman that I saw tested positive for her sister's familial mutation. She's been undergoing more intensive colonoscopy surveillance. She's had a hysterectomy to drastically lower her risk. And I'm now seeing her daughter, who's also at 50% risk, who's making decisions now. Does she wish to continue having a family? Does she wish to undergo hysterectomy? What are the pros and cons of that? And it really just highlights how, from that universal tumor test that happened at one woman's diagnosis, it's now affecting multiple generations and influencing the type of care that people get. But for that mother and that daughter, neither of them have been diagnosed with cancer. They have that opportunity to intervene. So I think for me, even saying that now, that gives me chills. That's what we're in this for, is that proactive
Yeah.
ability that we have.
Lynch syndrome is 1 out of 300 people. That's like the same as inflammatory bowel disease. So, think how many people with Crohn's and ulcerative colitis you all see all the time. That's how many people with Lynch syndrome you should be seeing. And so if you don't have any in your patient panel, you're missing them, not that you don't have them.
True. True, true, true. I don't think I appreciated that it was that common. What else do you wish that internists, subspecialists that are listening knew about genetic testing or with Lynch syndrome?
Sometimes we prefer to ensure the testing is done at the same lab as the family member who initially tested positive, for example. In Lynch syndrome in particular, there's certain inversions in the MSH2 gene or certain large deletions that can be hard to detect using certain test methods. And so on the back end, it's more work to sometimes ensure that the proper test was done at two different laboratories and collecting a positive control from the affected relative versus selecting the laboratory the same family member was tested at. Different hereditary syndromes are caused by different genes and different specific familial variants from family to family. So we really need to ensure that the test ordered is going to detect the known familial variant responsible for the reason that family has their hereditary syndrome.
I see, I see.
But there are a total of 20 to 25 genes associated with an increased risk for colon cancer. And it's very common practice now for people who have genetic testing to have panels that include all of those susceptibility genes. And so if we only have testing for Lynch syndrome, we've missed quite a bit of potential hereditary risk. So if someone's diagnosed with Lynch syndrome who does not have cancer, there are really three main areas where their medical care may change. So they would potentially have increased screening for the cancers related to Lynch syndrome. That's going to be some combination of starting screening at an earlier age. So, for example, people with Lynch syndrome usually start having colonoscopies between the ages of 20 and 30, as opposed to 45 in the general population. It may be that screening is done more frequently. So colonoscopies are done every 1 to 3 years for people with Lynch syndrome, as opposed to every 10 years in the general population. And they may have screening that most people don't have. So, for example, people with Lynch syndrome are supposed to have upper endoscopies every several years. There may also be medications that could reduce risk for cancer related to Lynch syndrome. So, aspirin, for example, can reduce risk for colon cancer. We know that's true in the Lynch syndrome population specifically through a lot of good work that John Byrne has led out of England. There may also be benefit in birth control pills and reducing risk for uterine and ovarian cancer. And then the last prong of screening and prevention would be surgical prevention. So women who have Lynch syndrome are usually encouraged to have their uterus and ovaries removed because we don't have effective early detection for those cancers. People who have Lynch syndrome with a diagnosis of cancer may benefit from immunotherapy. So if their tumor has mismatch repair deficiency, we know that anti-PD-1 immunotherapy is effective as a means of treatment. It was first proven in the metastatic setting, but is now also being shown to be true in the neoadjuvant setting for earlier stage disease. And then I think where we're really at the cutting edge is the idea of vaccines as a preventive option for people with Lynch syndrome. That's something that a number of people are doing research on that seems pretty exciting.
Immunotherapy was a game changer. The thing that I always point out to my Lynch syndrome patients that unfortunately get cancer, but patients with Lynch syndrome matched up with patients without Lynch syndrome, even without immunotherapy, have better cancer outcomes. If you have Lynch syndrome, you're going to be increased risk for cancer. But thankfully, if that comes up, then you're going to be very responsive to treatment. And we're going to do everything we can to watch you as close as possible where that doesn't happen. But if it does come up, that's the silver lining.